Thank you very much. This is my third trip to Taipei, and I love it. So I'd like to thank the Academy for asking me to present these papers from ESHRE. My job is really to summarise some of the things that were talked about in ESHRE when it comes to quality assurance programs, as well as monitoring and data collection from ART around the world. So let's start. The first one it was from Anna Ferretti, who, as you probably know, is the outgoing chairman of the EIM, the European IVF Monitoring. And this report that she presented was a result of treatments that were initiated in 2010. The data was collected. The data was collected from existing national registers around 30 countries in Europe, and they were directly entered into the EIM database, and then software that was manufactured by ESHRE was then used, and it was analysed at their headquarters. You can imagine quite a large database. What it revealed was some of the less optimal outcomes of IVF, such as the incidence of multiple pregnancy, the incidence of ovarian hyperstimulation, but also the pregnancy details from IVF, ICSI, frozen embryo replacement, egg donation, PGD, and multiples, as I said. You can imagine quite a large database, 976 IVF clinics. This is about 86% of the registered clinics in these countries. 939 IUI units were represented. And as you can see, about 70% of the treatment cycles, that's about nearly 400,000 cycles, were IVF and ICSI out of a total of 500,000 treatment cycles. If you add these together to the ESHRE database, they now have a cumulative total of about 5.3 million cycles since they instituted this monitoring in 1997. They also had large amounts, as you'd appreciate, of frozen embryo replacements, egg donation, PGD, in vitro maturation, and frozen oocyte replacements. The preliminary data comparing 2009 to 2010 showed that it was somewhat stable in terms of the number of cycles, but they also agreed that there was still a number of countries that had yet to place their data into the database, and so they assumed the numbers would rise. The data on IUI using husband's sperm and also donor sperm came from 21 countries, and a total of nearly 200,000 cycles of IUI, mainly, of course, was husband insemination. For IVF, you can see the clinical pregnancy rates per aspiration, per egg collection, and per transfer were nearly 29% and 33% respectively, and that was quite comparable to the previous findings of the previous report in 2009. The delivery rate per aspiration was around about 25%, and this had gone up a small amount since the previous report. For ICSI, very similar pregnancy rates of 29% per aspiration, 32% per transfer, and a delivery rate of about 20%. For frozen embryo replacements, the pregnancy rate 20% per thawing, 22% per transfer. I appreciate there's a lot of data here in numbers. I guess the reason for these international registers is for us to keep an eye on what's going on around our peers, but also to see how well we're doing as well compared to the average number, the averages of our neighbouring countries. In oocyte donations, you can see the pregnancy rate and delivery rates were 48% and 34% respectively for transfer and collection, and this would of course reflect the younger age of the donors. For PGD and PGS in the fresh cycles, the pregnancy rate 36.5% per transfer. And for in vitro maturation, you can see the pregnancy rates and delivery rates 14 and nearly 9% per aspiration respectively. And about 4,000 replacements after oocyte freezing, most of these coming from Italy and Spain, showed a 25% pregnancy rate and a 15% delivery rate per thawing. The IUI results are down there at the bottom. You can see the pregnancy rate of 12% and a delivery rate of 9%, but if you use donor sperm, as you might expect, those increase to 18% pregnancy rates and 14.5% delivery rates. This is the part I found interesting, the transfer of number of embryos here. You can see that around about only 26% of the embryo transfers used single embryos. 56%, which was the most common number of embryos, were double embryo transfers. Still 18.9% were for 3, and there is still a small number, 1.7% of cycles were 4 or more embryos. And of course, there were huge national differences in both philosophical and scientific approaches to these problems, and that's why these differences were quite marked across different countries depending on their particular unit policies as for embryo transfer numbers. The proportion of singleton pregnancies, 80%, twin pregnancies, 19%, and triplet pregnancies, 0.7%. These, encouragingly, are at least a little bit less than the previous report, but still, by comparison to perhaps world data, might be considered too high and what we are aiming to reduce in years to come. The proportion of, and what we of course are talking about is preterm deliveries for these multiple pregnancies. In this particular data set, 3.3% of babies were born before 33 weeks if they were from singleton pregnancies. But of course, as we all know as obstetricians, 13% were born prematurely in twins and 48% in triplets. This is what our paediatric colleagues are on about to get us to reduce in years to come. In IUI, women below 40 years of age resulted in 10% twin rate and 0.7% triplet pregnancies. So there's still room for improvement in those areas as well. This is just a different way of looking at it. You can see this is a summary of what I was just explaining. 33% pregnancy rate. Again, these are per transfer. 33 for IVF, 32 for ICSI, 22 for frozens, egg donation of 48%, as you'd expect, and higher for PGD, given the screening system built into those embryos. Again, I think I stressed to you that none of this relates to implantation rates. None of it relates to the number of embryos that are being transferred to equate to those pregnancy rates. Again, once I said, the majority of embryos transferred are 2 embryos, and there's still a large number of 3 and 4 embryos being transferred, and a twin rate plus a triplet rate of just under 20%, but at least marginally less than the previous period that was studied. The incidence of OHSS is what we would all probably accept as being reasonable at 0.6%. So the conclusions that were made with the pregnancy outcome was similar to the last 3 years. There were fewer numbers of embryos were transferred, so that's heading in the right direction. And there was, thank heavens, a decline in the multiple pregnancy rate of 2010 over 2009. I want to move on to another study found interesting, which was on fertility awareness. This was basically a comparison of what patients thought about their fertility chances compared to what their doctors thought. And this is an American study, and they took about 1,000 patients who were between the ages of 25 and 35. They had not been pregnant, but they had at least discussed with their healthcare provider the concept of either fertility or contraception in the previous 12 months. So they answered a questionnaire on what they thought about their fertility chances being. And then this was compared to how well their obstetricians and gynecologists, as well as reproductive endocrinologists, what they understood about their patients' knowledge of infertility. So this is a report that was self-administered in 2012. It was web-based, so a whole number of doctors answered this questionnaire in 2012. About over 300 doctors, 250 OBGYNs and 59 reproductive endocrinologists. And these doctors had to have at least been in active practice at the time, and they were compared, as I said, to the patient data which had come out the previous year. This is a more diagrammatic way of looking at what we're talking about. This essentially is trying to compare the patient's interactions with their doctors and also to measure the doctor's interactions with their patients, trying to assess whether each is on the same page in understanding what their fertility potential might be. Interestingly, the obstetricians and gynecologists consistently overestimated the proportion of patients that were likely to seek infertility treatment if they were having trouble falling pregnant. So 57% of the doctors thought that their patients would seek treatment, but only 21% of the patient population thought they would seek treatment. Another more complicated way of looking at it, we found that most women who were surveyed didn't seem to understand the potential impact of age on their fertility, so that the doctors were overestimating what the patients, how much emphasis the patients were placing on age. Only 39% were aware that a woman, this is of the patients, 39% of the patients were aware that a woman aged less than 35 is considered infertile after 1 year, but 83% of women were not aware that after the age of 35, a woman is considered infertile after 6 months. You can see down the left-hand side at the bottom there, you can see what you and I might understand as the normal facts of fertility, that 20 to 24 years of age is the time of peak fertility, that perhaps menopause falls between 50 and 54, that 10 to 20% of patients have infertility problems overall, and that 70 to 90% of patients more than 40 years of age have infertility problems. These are acceptable factors that you and I might consider, but interestingly, not many patients understand this. Only 45%, 46%, and when it gets down to the other two questions, 15 and 12% of patients understood these problems. What it's showing is that what you and I think our patients believe is quite different to what the patient actually believes. If we look further and we see that the beliefs that women who receive medical treatment have higher risks of multiple births and about egg freezing. So again, this was where the tables were turned. This is where the doctors actually underestimated how much their patients knew. About 82% of the patients believe that they can have eggs harvested and frozen for later use, whereas the doctor's understanding of that was much less. And again, when it comes to increase the multiple pregnancy rate, 74% of women understood the risk of multiple pregnancy, but only 43% of OBGYN doctors thought that their patients would know that fact. So at least some of the messages might be getting through to the patients. It's just a little bit slower getting the message through to the doctors. So some of those conclusions then, the results from these two studies, I think they show some insights into the patient knowledge and how that knowledge is perceived by doctors. You can note that the OBGYNs overestimated the proportion of women that were very likely to seek infertility treatment. More women believed infertility drugs to be effective than the doctors estimated, and women understood more about infertility treatment, including the risk of multiple births, than was expected by their doctors. More women understood that eggs could be harvested and frozen than their doctors estimated, and as this becomes relevant because women aged between 25 and 35 make up an important segment of those patients that we see as healthcare providers. So it's very important to tailor the information that we provide to our patients so that it's accurate and appropriate to help our patients optimise their treatment. I want to move on to another paper that talks about quality management and regulation of the ART lab. This is a Belgian study by Tillerman and colleagues. We know that when we run an IVF program, that we are under constant pressure to improve the quality of our services and to increase the percentage of successful cycles. So we often use quality control systems. And this particular paper was very much about a quality control system that's available in the industrial or commercial world, and it was made to be used in an IVF setting. The aim was to establish procedures, standard working methods, which ensure that these established levels of quality are reached and maintained. So it's not just about having quality, it's about instituting a program that can maintain that quality over a period of time. And of course, these parameters must be visible and measurable, and they must be adhered to and be able to be maintained. So this particular paper really came out of Ghent in Belgium, where they initially started using the ISO 9001 and ISO in 2000 and 2008 for their certification, but then they extended their quality control, their total quality management by using this industrial tool, because they were now having to subject themselves to European directives because they were becoming a tissue bank, and a lot of onus was placed upon them by external bodies to maintain their quality control. So what they used was a process-driven approach that came out of the Lean Six Sigma management system, and this is a management tool that's used in the industrial world and the commercial world to improve efficiencies and, more importantly, to reduce waste. And these laboratory processes and treatment plans that were being used in this IVF laboratory were using a specific, what's called SIPOC tool. Now, SIPOC stands for Suppliers, Inputs, Process, Outputs, and Customers. So again, it's just people out there in industry making use of the tools that are already available, introducing them into our IVF units, and making use of a process that we can maintain good quality control. So this could be anything related to starting with eggs and sperm and ending up with embryos in your laboratory, right through to the patient when she first walks through the door to when she might walk out the door an hour or two later. So we're talking about the suppliers, the provider of the inputs to the process. We're talking about inputs in the progress, which might be materials, resources, or the data that's required. The process itself, which converts inputs to outputs, and that can be a whole number of separate steps. And then the outputs are measured, and also the customers, which may equally be the patient on one end, but it could also be the lab technician, it could be the embryologist, it could be the clinician. We all have certain needs, we all have certain quality control built in, and we also can be the customers inside our own IVF unit. So what they found in instituting this type of approach as a quality control mechanism was that it was relatively easy to use, it increased their efficiency, they felt it led to a better job understanding, and it streamlined their workload. They also found that one of the additional bonuses is it reduced waste. So what they've done is they've turned what is a definition of quality might just be conformance to requirements, but they've turned it into a total quality management approach so that they are continuously improving the quality of products and processes. This goes on further because their requirements were the requirements upon their own unit had increased because they had European directives, just as you do here, as we have all the way around the world. We have both national bodies, we have legislation, we have ISO certificates, we have laboratory accreditations. There is a great amount of requirements on our lab to maintain quality. So one of the things, what we're trying to do is improve the quality of products and processes, and these could relate anything towards the material we're dealing with versus the patients, the staff, the procedures, and hopefully these will lead to management reviews and to improve quality control. So the European Tissue Culture Directive and the national laws made it necessary for this unit to apply a quality system in every IVF laboratory and fertility centre. It led to high demands and expectations of the patients. They are on top of the working standards that we all like in our laboratory. Every laboratory or clinic had to demonstrate its ability to consistently provide a product, and the product might have been as simple as a pregnancy or the care of the patient or the services within the lab that meets not only the customer, and as I said, that customer could be the doctor or it could be the patient, and also to conform to regulatory requirements, and all the way along in trying to enhance customer satisfaction. So they felt that they were very much an ongoing process. They were still in the process of learning, but the conclusion they drew was that using this sort of industrial approach, a SIPOC approach, was found to be straightforward, easy to use, and with a maximum of information on return. The next paper I wanted to present to you was basically out of Cape Town. Now, Cape Town, or South Africa, is a country that was not, up until about 2007, was reporting their data. So at a meeting of ICMAT, the International Committee for ART Monitoring, they met in 2007 and helped South Africa to put together a database so that they could report into this international body. And as soon afterwards, 2009 and 2010, South Africa were able to produce these sorts of figures. So in the space of just 2 years, they were able to present to the international colleagues that they had now 12 centres in 2009, going up to 14 in 2010. You can see that they were able to report on the number of egg collections they were doing, also their clinical pregnancy rates and their ESHRE rates as well, and the percentage of ESHRE in terms of the total number of cycles that they were undertaking. So they had actually confirmed, they had transferred themselves from someone that wasn't reporting internationally to a country that was able to report to ICMAT. Some of the stuff that came out of their report that they were finding interesting was their age span of the female. As we would get used to in our aspirations, we see that about 50% of those patients were under 35, and of course fewer in the older age group. That's a little different to where I come from. Those bars would be a little bit different, and I'm sure they're probably different for you as well. But the pregnancies, as you can see, the majority are in the younger age group, and that was the summary of their some of the studies that they put out. Their ESHRE results, you can see here, this was a total number of embryos and blastocysts that were transferred. Still a very worrying number, I think, and I know I carry on about it, but it's always very nervous to see still 3 and 4 or more embryos being transferred, especially in such large numbers of patients in the older age groups. But at least they're now having to stand up to international scrutiny as a national body. So the whole aim of this study and this presentation at ESHRE was to tell the world that they were now reporting internationally, that they had taken ownership of this particular process. They wanted to be thankful to ICMAT for helping them get their database up and running, and they found it useful to get around to see all the individual units for some sort of accreditation procedure. What they didn't think was still doing so well, it was very time-consuming, as we all find when we have to collect data. They found that the tools that they had for data monitoring were not too bad, but to actually go on and collect the data for international analysis was harder. And they're still a little worried that they've only got 3 units who'd submitted their data for 2011. So I suppose it's all about maintaining the enthusiasm, getting around the units and getting them to produce their data. And of course, they're still looking for funding because these sorts of things don't come cheaply. What they're doing, though, is they've set up a sub-Saharan register for ART. So they're actually starting to form a regional body, and this will expand their efforts. They're trying to overcome the political and problems that they face on the African continent about different policies and the way that they can report. They're still desperate to find funding, but they feel very hopeful that in the next couple of days, when they meet their first FIGO conference in Ethiopia, which is next week, they're hoping to cement a number of these initiatives. I wanted to finish up with what I consider to be one of the largest data collections I've ever seen. This was David Adamson's report out of California, he being the president of ICMAT, the International Committee for the Monitoring of ART around the world, and he presented the preliminary world report from 2009. He commented that the ART, of course, is now practiced globally. It's important for us to share information on both the access, effectiveness and safety of ART so that everybody who's involved in IVF, whether they be patients, doctors, scientists or legislators and governments, they can maximise the benefits of this rapidly evolving technology. So what they've tried to encourage national registers, if not regional registers, because they are they're very dependent on these figures being produced and collected and analysed. ICMAT collects global data annually from these regional directories, as I said, and they focus on the number of clinics, the number of different types of ART services, and the cycles. They also try and focus very much on the effectiveness. So we're looking at not only pregnancy rates, live birth rates per egg collection and per transfer, but also the safety. So that we're also looking at the problems that go along with IVF, such as multiple pregnancy and OHSS. They looked also at pre-implantation genetic diagnosis and surrogacy, have also been documented in this report. And they report this at international meetings such as ESHRE and the ASRM. They also pat themselves on the back because they are helping developing countries to develop their own national registries so that this can be a worldwide phenomenon. And as I said, recently they've helped South Africa do just that. If we look at some of the results, you can see here that we are looking at over 1 million treatment cycles around the world from the 2009 report. This is an increase of 2% on the increase from 2008. And you can see the 9 countries that are listed there produce about 70% of the data. The largest country, as you'd expect, is Japan, followed by the USA. But of course, it's very population dependent. It would be an interesting fact to see what the penetration in each of those countries was. But you can see a large number of the cycles coming from a small number of countries. The registers, the regional registers include ESHRE, which all those countries are listed. Australia and New Zealand tend to combine our data. We've been collecting data in IVF since the very early days in the early 1980s, so we're very proud of our large collection data, so it's relatively easy to provide this into an international body. Latin America is expanding with those countries you can see there. There are regional organisations including North America, which includes Canada and the USA, of course, and the Middle East have banded together those countries there. And then after that, you drop down to national registers. So there's Israel, Japan, Korea, South Africa, and sometimes even individual clinics are reporting in the smaller countries. There are still huge gaps, and the ones that you would be obviously missing, of course, China and India. It's estimated that what this report comes up with from 59 countries is approximately 80% of the clinics around the world that are providing IVF, but there's still very much the missing countries there of Africa, Middle East and Asia. We think that we've got about full coverage from 27 countries, and it's estimated that this report covers only about 2/3 of the total IVF cycles in the world. It's still a very large database. We can still learn a lot from it, but we need to lift our game and get the remaining 1/3 cycles reported and responsible. If we go on and look how that's made up graphically, you can see most of the cycles around the world are coming from Europe. This is from this report. I'm not saying it's correct. I'm just saying in this report, the majority of cycles come from Europe, North America, and Asia. You can see the countries that are involved in those particular areas, totaling a total of 59 countries all up. And as I said, over 1 million initiated cycles with approximately 196,000 deliveries. Of those aspirations of 700,000, you can see the delivery rates there, combining IVF, ICSI and a little bit of GIFT at nearly 23% delivery rate, and an 18.7% rate for thawed frozen cycles, PGD of 9.5, and egg donation at 33. These are large numbers, just giving you a ballpark figure of how the averages work around the world. You can see if we look at the particular type of procedure, well, GIFT has all but disappeared from the world from 1995 through to 2009. Only individuals doing GIFT these days. But you can also see, interestingly, the rise in ICSI as a percentage of the total number of cycles. Interestingly, in the last year or so, it has flattened out, if not dropped. And it doesn't account for why there is such large variations in these percentages. If we look at the particular areas, you can see quite a large variation in the percentage of ICSI cycles compared to IVF. in some countries as high as 100% or close to it, and around Europe down at 70%. So why there should be that different, why those demographics of those males should be different in those regions is very hard to understand, but of course these are just different philosophies in the units as to how they practice IVF. If we go one step further and look at by region what the success rates are, I don't think this slide helps us greatly at all. We can see that North America has high pregnancy rates, but we know they have high multiple pregnancy rates because they transfer at least 2 embryos. And I think what we should be looking at, of course, is the cumulative pregnancy rate with time and to reduce the multiple pregnancy rate. But you can see the fresh cycle and the cumulative pregnancy rates from different regions around the world. I think it gives us an idea of what our colleagues and our neighbours are doing, but we need to learn a lot from these. So some of the conclusions that David Adamson drew from his talk, he reported, as I said, over 1 million cycles, which is an increase in 2% on the previous report, estimated that there are about 1.6 million cycles of ART around the world each year. We've had nearly 250,000 babies born, which was a slight reduction on the previous report. It's estimated that there are around about 400,000 babies born from ART around the world, and that gives us a total of about 5 million babies born since the beginning of, since Louise Brown from Steptoe and Edwards. 67% of the cycles tended to be ICSI, and 20% of the cycles were in women more than 40 years of age. The mean number of transferred embryos still is too high, 1.97 embryos. At least it's heading in the right direction. It is a slight reduction of 0.11 on the previous report, so thank heavens it's heading in the right direction. The delivery rate per aspiration, around about 20%, and a cumulative pregnancy rate, if you add in the frozens, around about 26%. But the take-home message is there are still wide differences in availability, practice and results for different countries and regions. ART thus is widely available globally, but individual patient access is highly variable depending on funding for the patient, depending on legislation, depending on religious beliefs. It's an effective technology that's being applied differently in different parts of the world. It is generally safe, but multiple pregnancy remains the major concern. And ICMART's World Reports on Global Access, Effectiveness and Safety help to create the opportunity to improve the provision of ART services globally. And the development of national registers still remains an essential component of what they are trying to achieve. Thank you very much.
Thank you very much, Professor Porter, to share so much information with us according to ESHRE, the World Report. It's not very easy. It's a huge amount of data over here. I wonder, is there any comment or question from the audience? Okay. But I think this data didn't include the cycle of China, right?
Cycle?
Of China.
No, it doesn't. China will make a huge difference to these numbers.
I think China probably have a 300,000 cycle last year.
Yes,
yep. So, but from the ESHRE data, it's very powerful because it accounts for more than half of the cycle in the world. Yeah.
I think this is very much a name and shame. These are the good boys. Could we please get everybody else's numbers in, please?
Sure.
Yes.
Okay. No more question, no more comment? Okay, we thank Professor Porter again, yeah. So,